Okay, good morning. Welcome to Project Echo. Today we've got John Massey talking about prescribing buprenorphine for pain, as well as opioid use disorder, I believe. Just our usual disclosure of relationship slide here. No, nothing disclosed among those involved in this project today. Then our usual funding statement. We're a grant-funded project. Our grant funds come ultimately from a SAMHSA grant that come to us by way of Nebraska Department of Health and Human Services. And usual process for CME certificates, there will be a link in the chat and a link coming to your email later this morning for to complete a survey. Once you complete that survey, I will email out your certificate within a couple of business days. And this is the last Echo series and Echo training in this current series. We do these in cycles of 4, as I think most of you know. So we will be off in September, and then we will be back in October and November with another cycle of 4 trainings. And here's what we've got lined up. The first one is kind of work in progress still, but it'll be from the UNMC harm reduction advocates. Then Mary's doing one on healthy living and substance use disorder treatment. We've got another guest, Kelly Dorfmeyer, coming on to talk about cognitive behavioral therapy for chronic pain. And then we're going to end the series out with Stephanie's talk on trauma, PTSD, and SUD. So that's about all I've got for intro stuff. I'm going to let our experts introduce themselves, and then we will get on with Dr. Massey's talk. Let's see, Mary, would you like to go first?
Sure. Good morning. I'm Mary Ellis. I am a psychiatric nurse practitioner and an attorney here in the state of Nebraska.
Thanks, Mary. Todd?
Good morning, Todd Stull. I am a psychiatrist and involved in addiction medicine as well.
Thank you. Alex.
Morning, Alex Dorick, underserved family medicine in Omaha.
Thank you. And let's see, Stephanie. I don't think Stephanie Bennington's on yet. And I know Ed Kaiser's driving out to a conference. He's coming out to join me in Kearney for the Emergency Medicine and Trauma Conference. We're out here just kind of talking to folks about our Project Echo this morning and this afternoon. So Ed's a nurse practitioner doing substance use disorder treatment. John, I think I'll let you take it from here.
All right. Well, good morning, guys. I'm John Massey, and a pain doc, and I'm going to be talking a bit today, a little bit more about buprenorphine as it relates just to chronic pain, not specifically the um, as we use it for OUD. And I think it's a very pertinent field. Hopefully this is a practical talk that works for you. Does this look like I'm sharing?
Yeah, I can see it. I think you just got to go to the presentation mode and
There we go. All right. So here's what we're going to be doing today. I want to talk about, why buprenorphine is a good idea for chronic pain, fully separate from how we use it in MAT, MOUD. That's a little bit about the receptor. It's a little bit about the physiology of chronic pain, and therefore some of the sustainability issues, et cetera. Also, try to debunk some of the misperceptions about it. I think that's been a little bit of a challenge because of all the data waiver. We've talked about that in the past, and then hopefully get some time to go through some sort of practical ways that this can work. And just specifically, I'm working off some guidelines that we have been working on making for the pain guidance document, but also very interestingly, the Department of Defense and separately the VA system has come out with a lot of these guidelines as well. They're really at times, despite the fact that we feel frustrated by military medicine and VA medicine, they have numbers and they have data and they have the patients with these problems. So when they come up with guidance, it's oftentimes very translatable to us in private sector. So that's one of the things that I've noticed about this. But here's the clinical problem, and I think we need to really speak a little bit about the chronic pain physiology. I talk about that more often than I probably you all would wish, but remind yourself that chronic pain is not just long-term nociceptive pain. It's nociplastic pain, central sensitization. It's central nervous system alterations that occur in the presence of an injury or a disease state that are ubiquitous and present to one degree or every or another for almost every patient. And that is why buprenorphine has a unique ability to be beneficial in those kinds of patients. Um, how do if you talk to people and they're prescribers of opioids, say for their patients with chronic pain, if you say, how do you define when it's a good idea and when it's a bad idea, they always go to something like, MME and the CDC guidelines, or they talk about, well, I just want to make sure they're not a drug. They just don't have a perception of what to do and what not to do. And part of that is that the benefits of opioids for chronic pain are actually negative in many instances, but they're not what patients expect them to be. People don't have a good understanding of when the physiology switches, and they get into therapy that they get into the idea that then they have to withdraw. And how do you determine dependence versus efficacy when a patient experiences an increase in pain when they're going into abstinence syndrome? So it's really, we have to be smarter about that and understand that, it's not about writing drugs for somebody and then when you get nervous, you switch them over because I'm nervous and now I'm not going to be in trouble from somebody. It's what's the right thing to do clinically. And, it doesn't involve when a patient starts taking more medicine, you force them to taper or you fire them. It involves doing something better. And so I want to be giving people a way to manage through that set of circumstances. So why is buprenorphine special in the regards to? I won't show you a slide today, but I'd ask you to either challenge me on it or I'll give you the data that says most chronic pain states are not opioid responsive to the degree that patients think they are, if at all. And there's really gathering data that says in a great number of instances, opioids, when you measure them in large volumes over time in lots of patients, are actually deleterious for chronic pain patients. And that's because of what's going on with the physiology and the kind of sequela of it that are irrespective of the development of dependence. And buprenorphine is a unique molecule. It's a synthetic opioid-like medicine. When people think of it as a partial agonist, that's really just with respect to respiratory suppression and what it does at the receptor. But with respect to analgesic efficacy and what it's doing at the mu receptor, it's very good at activating the mu receptor. And just because it's a partial agonist doesn't mean it's partially effective. As you increase the dose, it is increasingly effective for pain physiology at the mu receptor, which is what we want. Also, the other effects, the nociceptin receptor, which we want, it does contribute to mood modulating effects. There is increasing evidence that shows that there's a useful quasi-antidepressant effect with buprenorphine. And I think that is especially true when you consider that there's probably some evidence that suggests that opioid management is contributory to worsening of mood disturbances. So when you look at the combination of these, mood changes, those central nervous system changes are part of what the chronic pain experience is, and buprenorphine is beneficial, whereas our other opioids are not. And then the fact that at the kappa receptor, it's an antagonist. The kappa receptor is that dysphoric, that I just don't tolerate that class of medication kind of a problem. And so the fact that it's an antagonist at that spot also contributes to the antidepressant activity for this. So these key receptor alterations from other types of opioids make it as a molecule more likely to be beneficial. But there's some other parts of this as well. We understand it has a very high affinity. The high affinity means that it will defeat other agents at that receptor site. So we can use this factor to help us switch patients over. But also, and importantly, the fact that it's got a very high affinity to the receptor means that as it sticks to the receptor, what it's also doing is it's kind of uncoupling those negative second messenger effects, whether they're just, which is probably overly symptomatic or simplistic to say that it's the dopamine effect, but those negative secondary effects that occur with off on of the mu receptor are pulled aside, not to mention, the continuity that you get. You suppress that opioid withdrawal longer than the analgesic direct action. So you will see in clinics such as ours, where we're using consistently using buprenorphine for pain relief, what we will tend to do that is different than so if somebody is prescribing, let's say they're giving 8 milligrams once or twice a day for opioid use disorder, and it's very common to say, just take that 8 milligrams once a day. It's got a 38-hour half-life, et cetera, et cetera. You'll be fine in the aggregate over time. You will see a lot of the time in a clinic such as mine, we'll be using 1 milligram or half a milligram or 2 milligrams BID, TID, even QID, telling the patient, break that up a little bit. And then what we're trying to do is use a smaller amount more frequently and taking advantage of first patient agency. They're used to taking a medication at that kind of dosing, so they feel like they have a choice as to how they take it. But probably also there's an effect of we're getting analgesic effect at that part of the day when it's most important. So just being able to understand how to do that, I think, is pretty helpful. And this is something that I think I want people to understand with respect to, yes, we have a ceiling effect on respiratory depression. The idea that you can suppress respiration really requires a whole lot of other stuff and intent and so forth. That ceiling effect on respiratory suppression means that you've got a larger therapeutic index, right? Because the ceiling effect on respiratory suppression occurs, but the increased analgesic potency or efficacy can occur over time. So that expands that therapeutic window for a patient. And also it means as well that that ceiling effect, there are a lot of opioid receptors that are not even engaged when people are in therapeutic doses of buprenorphine. Well, we'll talk about this a little bit more, but even perioperatively, it is perfectly acceptable if you have somebody being managed on, for example, chronic pain with buprenorphine, and for long periods of time they've been on 2 milligrams of buprenorphine or 4 milligrams of buprenorphine a day. If they go in and have a total knee replacement, or even if they're on high doses of Suboxone for MOUD, you can keep them on their buprenorphine and you can add in a legacy opioid without worry that you're going to precipitate withdrawal the way we used to think. And that's been a misperception that people have. So that allows us, that takes away the negative aspects of this. And the fact that those receptors are open, even at super normal doses, is very important. And we can use that stabilizing these patients. Yeah, we need to be cautious about these, obviously, with other CNS depressants and what have you. I think the point that's critical to make is that it's way better than anything else that would be used as an option. I can't tell you how many times a pharmacist has, or a pharmacy tech rather, patients switching out their 40 milligrams a day of oxycodone for, 2 milligrams a day of buprenorphine, and now they're getting the lecture about having naloxone. Yep, we want to co-prescribe naloxone when we're using Suboxone for MOUD. I would make the argument that if we're not working with a patient on dependence, this is not the time when we need to be doing that. You can consider the buprenorphine part of a naloxone regimen. This just means, we know the data waiver is over. That's probably why a lot of us are here. The stigma of the idea that buprenorphine needed its own special class in order to safely prescribe it has probably been our biggest obstacle, because it never ceases to amaze me that people are perfectly comfortable writing kind of way super therapeutic doses of oxycodone or Dilaudid or morphine or what have you, but they're just not comfortable with buprenorphine, and that just is that doesn't make sense to me. So we need to continue to fight that prior stigmatization of this molecule. It is true that when we're using buprenorphine without dependence issues, that we are very often in lower dose range than we need to be when somebody's been on, X amount of street fentanyl or what have you. Generally, in the therapeutic ranges, we find great success at 4 milligrams and under. That's different if patients also have dependence issues, but we can get a lot of analgesic efficacy at those lower doses. And the challenge for many patients is that because the high dose 8.2s of buprenorphine naloxone or the Suboxone on those different agents have been kind of forced to be onto formularies with insurance companies to make sure that they're allowing for treatment for MOUD. Those lower dose ranges have been on higher tiers, so it can be a prior authorization issue. We get around that very successfully, and I'll talk about that by using the larger milligrams and chopping those up. And there's a lot of ways to give lower doses of buprenorphine successfully that do not cost the patient any more than their legacy opioids. And if you understand how to do that, you can be saving these patients money while you're making them more comfortable and certainly more safe. This is in here because I got this slide deck is kind of coming from the new chapter, which does also talk about MOUD and buprenorphine. I'm not talking about that today, but remind ourselves, a lot of these patients are co-diagnosed, right? They have chronic pain that may respond to buprenorphine for chronic pain, and they may have some simmering level of dependence, and therefore you're helping them with 2-in-1 treatment here. And the important thing I think to understand with this for patients, I'll talk about this a little bit more later on, is that sometimes we don't know where that patient sits on that continuum, right? When you're talking about appropriately using opioids for chronic pain versus now they're developing some, instead of just physiologic dependence, they're getting some sort of simmering level of psychological dependence, right? What's the amount of alcohol use that equals alcohol use disorder? What's the amount of opioid use for a patient with chronic pain that is equivalent to opioid use disorder? Very hard to define. But what we've seen is that individuals with dependence do use a higher dose and prefer the higher dose, and individuals who don't have that get analgesic efficacy at a lower dose. We just get ready to treat them however they are. We meet the patient where they are, and afterwards you can have a discussion saying, maybe you were a little more dependent than we thought. Isn't that interesting? But you're going on. You can see very easily how that's a part of the destigmatization, right? It's like, I didn't think you were dependent. I thought I was just going to help your pain more, but you're using a little bit more, which suggests that maybe you had some dependence issues that was going on because you're in that range, but whatever, don't you feel better pain-wise? And we don't care what you think. And now the patient's like, oh, that's interesting. And they just feel better. So depending on where you start the patient, you use different strategies, and it's way easier than we thought it to be. And especially with respect to chronic pain, it's just much more simple. Again, if you understand a couple features of how the molecule acts at the receptor and how the patient's going to respond. Yep, many people are used, direct initiation is super easy. You'll see in this that there are some of our pain societies are advocating buprenorphine as the first line opioid to use for chronic pain. And I think for sure that's going to be an accelerating discussion. It's very effective early on at low doses, and patients appreciate that. They feel very clear-headed and what have you. So opioid naive patients, direct initiation, low dose, often transdermal. If they're opioid tolerant and you want to make it super easy for you and maybe not that easy for the patient, you can put them through some withdrawal and start them on buprenorphine. That's a problematic thing in many ways. Why do you want to induce discomfort in a patient that you're trying to make more comfortable? Why do you want to give them the anxiety of that? It makes it simple for you if you can avoid that. And we talk about the microdose induction. You just go from one to the other in a blended fashion, and the patient never has to go through that uncomfortable phase. So this one, this is kind of how you can do this in an individual who comes to your office. So this is a very interesting way to start this. So let's say a patient comes to you for the first time, and now they've just moved into your area. They're now your patient. You inherit this patient, and they're on just way over necessary doses of opioids. Maybe because it's the time they've used them. Maybe it's because of the lack of efficacy, that they come from an area that an individual didn't understand how you could prescribe differently. But they come to you and you think, I really need to switch these people over for them to be comfortable and safe. And so you want to take an opioid tolerant patient and switch them over. You can do something like this, 0.5 milligrams, a quarter of a strip, very slowly. And the day 1 through 7 is a very fluid thing. And I'll get to that. This is a slide for a little later on after we have a few patients. Again, perioperative and acute pain management. You'll see when most of the time when you're looking at pre-admission testing, you're looking at opioid stewardship committees and what have you, they'll sort of say, well, if a patient's on Suboxone for OUD treatment, get them to lower doses, discontinue it so that the surgeon can do what they want for management. We're getting away from that. Even high dose buprenorphine therapy for OUD is perfectly well maintained with Dilaudid or fentanyl PCA after a major surgery if they continue their buprenorphine dose. And then the neat part is when the postoperative opioid management is no longer necessary, you back that down, the patient doesn't get that irritable agitation because they're covered otherwise with the buprenorphine treatment. So if we can pass the word along to as many colleagues as we can that co-management of perioperative course with buprenorphine, and if it's on board first, it will win at the receptor and you can add anything later and it's not a concern. Where this also works for us is you have an individual that has a chronic pain and you're managing them, say, on 0.5 milligram 2 or 3 times a day of buprenorphine, and they come to you with a new fracture or dental pain that's something that's severe. You add in 5 days of oxycodone. Just tell them to continue the buprenorphine, add the oxycodone, and stop if you want to do it that way, if you're more familiar with that dosing. Alternatively, you can just increase the buprenorphine with at least equal analgesic efficacy. But the main thing we're trying to get people to understand is no point in pushing people off of buprenorphine perioperatively. So what does this look like? And I've presented some of these slides in the past, but interestingly, you'll notice that this is a pain medicine article from over a decade ago. And these were back in the days when it was more frequent to have people be managed on very high doses of opioids for chronic pain. And when it's not working, what do? Well, it used to be opioid rotation. It used to be gradual escalation. It used to be sort of carefully documenting why super therapeutic doses are in the best interest of the patient. And it never worked. Patients on these very high doses of MME for chronic non-cancer pain, managed with well-identified diagnoses, long-term management, tolerance, they get up to these very high doses of MME that kind of curl our toes, but we see this. People will do this from time to time. And what happens when these individuals who were in this study and they were all without a diagnosis of opioid use disorder. right? They were taking their medications as prescribed. They were functional. They didn't exhibit those aberrant behaviors that make us worry about psychological dependence more than physical dependence. And that's why they were being allowed to go up and up and up and up while their VAS was somewhere around 7 or 8. Very unacceptable management. These people were simply put in this study and switched over. And what happens is they go to buprenorphine, the supposed partial agonist, from classic opioids at supratherapeutic doses, and they get a 51% overall pain reduction, and more than 95% of the patients, I think it was 97% of the patients, specifically said, I prefer the pain relief that I get with buprenorphine to what I was getting with 1,000 milligrams a day of morphine. This is critical information because anytime you bring up this concept with a patient about, I don't think this is going well, I want to switch you to buprenorphine, you will inevitably and reasonably get a lot of anxiety on the part of the patient, and you will get this, oh, you don't believe me, you don't think this is real, you're going to give me a patience. And unfortunately, I guess probably I mean fortunately, if you understand this data, which I think is very compelling, you can confidently say, it's all about how we do it. It's all about getting you there. And I can't wait to see you in a week or 2 or 3 weeks and have you tell me, as everyone else does, thanks, doc, I feel so much better. My pain is better. I feel more like myself. I'm doing stuff. I'm happier, et cetera, et cetera, et cetera. And that is a very rewarding thing because now, whatever dose you found for them, they're going to be sustainably more relief. And if I have a chronic pain patient, and I think this is how anyone would reasonably be thinking of it. If I have a chronic pain patient who's been managed for years or decades with multiple kinds of conditions, and they consistently come in and say, on a bad day, my pain's 4, and on a good day, my pain's 3. They will take that. We will take that. That's functional. That improves their quality of life, their family relationships, their employability. Everything is better with this. And this is just a single step. But you have to understand that in a transitory fashion, it might be a little challenging, but that's why we're talking today. This is a study that's a little bit newer, but really, when you're seeing this buccal film conversion, what you're really seeing is individuals who are switching over into fairly they're higher dose patients because the transdermal formulations really only go to 480 micrograms a day. That Butrans patch is the highest at 20 micrograms an hour, which is 480 micrograms is 0.48 milligrams a day. And when you're using the buccal film formulations, that's on the very low end of this. So mostly the buccal formulations are higher, but even then, when you study patients, it's very easy to switch them over. And once you do, they're happier. The other part about this that's very interesting is that individuals will very often say, well, but I need a lot of medicine to be comfortable. I'm not on, I can't use partial agonists. They think of it like a tramadol or something. I need a higher dose to get more relief. And what this study was very good about showing us is that it doesn't matter if you've got an individual who's at a lower dose of MME, so under 90. So this could be that individual who's taking 20 milligrams of oxycodone extended release twice a day, and then adding in some quote unquote breakthrough opioids, 10 milligrams of hydrocodone a couple times a day or something like that. They're going to get just as good a relief of their pain with buprenorphine as somebody who comes in and they're on MS Contin 60 milligrams TID plus some additional oxycodone or something. These people will still do better no matter what their range of opioid utilization prior to switch is. So with all this in mind, um, uh, the consensus statements that are coming out from American Academy of Pain Medicine and several other organizations is let's use buprenorphine for chronic pain treatment as a first line of treatment, because if you're dealing with chronic pain, buprenorphine is more effective, more sustainable, and safer for the patient. And we just have to get familiar with it. And the thing I like about when we see Lynn Webster is a very well-known pain doctor who's been in Utah for years. He's really been an advocate for long-term fashion for the use of opioids in certain pain states. In other words, he's the kind of guy who needs to be convinced. He's as a bit of side effect, he was born in Lyons, Nebraska, and grew up in Lyons, Nebraska. And I just got this book because I'm interested in this, but this book here is about deconstructing toxic narratives. And it's kind of an interesting one for this group if they're interested in it, because basically what he's talking about in this is that, everybody wants to blame the Sackler family. They deserve blame. Everybody wants to talk about, the cartels. They deserve blame. Everyone, but now the sort of media circus that's around opioids and fentanyl in particular, the concept that you can't watch a TV crime show without some policeman, quote unquote, touching fentanyl and going out, just how that toxic narrative about this is something, they're looking for who to blame and who's the bad guy. And their point is the bad guys aren't the biggest problem. It's just kind of bad science and bad medicine. And I think that's a very timely message and a very balanced message. So how do we speak about this? Partial agonist does not mean partial efficacy. Sublingual buprenorphine is as good as IV morphine for kidney stones. Okay? 2 milligrams of buprenorphine sublingual is effective to 10 milligrams of IV morphine for somebody with an active kidney stone. That's a study that opened my eyes in many ways, because that's not where I would think to use this medication, but it's very potent with respect to what's going on. So what are the other things? Again, I talked about the therapeutic index. The reduced incidence of tolerance, I think, should be talked about. We know a treatment for chronic pain works when it's sustainable. I care a little bit about what a patient's going to say in the first 4 to 12 weeks of our treatment, right? I need to make them better as fast as I can, but I really want to find some treatment that's going to work just as well at 5 years, because these patients are going to need that. And if you want to compare buprenorphine to other agents, we shouldn't just compare it to opioids. I told you already that we can show you data that said opioids don't work in the long term because of nosoplastic physiology. You're like, okay, well, I'll just use XYZ. Well, if you're using membrane stabilizer, okay, let's say this. If you're using muscle relaxants for chronic pain, even as perceived to be muscle, doesn't work. There are numerous studies, meta-analyses, which show management of patients with muscle relaxants for more than 3 weeks is associated with a worse outcome than doing nothing. So stop using muscle relaxants for patients. What we're doing is sedating them so that they aren't reporting the same kind of problem. We're making them less functional, and we're getting them dependent on another agent. The same is true for a lot of the ones that we'll use instead. People feel gabapentin and pregabalin are effective. They can be. There's a role for these. But when you really look at the membrane stabilizers, unless for a neurogenic state, unless you can get a patient into the 300, 450, 600 milligrams a day of pregabalin, which, as you know, would lead to a lot of difficulty for tolerability, you're not really separating meaningfully with respect to the amount of reduction that you sometimes get. You can get a 30% reduction in pain. You can you can do that. But when we look at the other agents like Keppra and Topamax and all these others, it is very difficult to get a patient to say I'm 30 or 50% better with those agents. And most of the time, it's a number needed to treat problem. The number needed to treat for all of those membrane stabilizers is somewhere between 9 and 11. And I would just say, I'm pretty sure from the patients that we see and our referring pattern, if people come to us and they've had to go through 9 or 10 different membrane stabilizers, a lot of clinicians are going to quit trying. That doesn't work. The same can be true with serotonin norepinephrine reuptake inhibitors, specifically the medications like duloxetine. You do get a good evidence for a sustainable benefit with chronic pain in individuals with various states with duloxetine, but you're typically 60 milligrams BID before you really see a sustainable and very notable effect. It's often hard to get a patient when we're starting at 20 milligrams a day or 30 milligrams a day. That's a lot of titration before you can get them to tolerate it, not have nausea or orthostasis or what have you, and get that benefit. So there is, the data does separate with respect to buprenorphine and long-term management of chronic pain states in a sustainable fashion. And that tolerance is why when somebody does do well with pregabalin, for example, where they're on 75 milligrams TID, the nice part about that is what relief and tolerability they get at 3 months, we expect to last and be present at 5 months. Same would be true with the SNRIs. The same is true with buprenorphine. Nobody would say it's common for an experience to say, well, if I start, Mr. Jones on 5 milligrams TID of hydrocodone, in 5 more years, he's going to be on 5 milligrams TID. No, he's not. He'll be at a higher dose because that molecule isn't working. With buprenorphine, if I get a patient to 1 milligram or 2 milligrams of buprenorphine and they're feeling pretty good about that, I can say it's the universal experience we have, just a great preponderance of those patients that at 2 years, 3 years, and 5 years, they're just calling every 3 months and can I have my 2 milligrams a day back? It just fits into the schedule with pregabalin or what other things we're doing. And think about the freedom that gives the patient and think about the benefits to your practice, right? Now you're not getting those phone calls on Friday afternoon like I ran out because I took a little bit more, or I've been increasing, or I've been in the ER, or can we just change that dose this one time, doc, et cetera. We've all heard those kind of discussions. You don't have that. That problem goes away. And how disarming is that for the challenges and the frustration in your day? It makes managing chronic pain like managing hypertension or managing, really probably better mood disorders where somebody says, you know what, actually, I just really like how the Lexapro makes me feel. We got there. We're on the right dose. Thank you very much. You just see them to renew that medication and make sure things aren't starting to change. Very rewarding, and it destigmatizes those patients for a practice as well as for your own professional. So what are the key recommendations? Don't let a patient don't let a patient Google doctor talk you out of this kind of an option. Help them understand it. So when somebody is developing tolerance, one of the aphorisms in our practice, and I think it's shown out with data, that once you take a patient who starts on something simple, let's just use that 5 milligrams TID of hydrocodone, and it's been working, and the first time they say to you, could we go to 7.5, or could I have one more a day for a few days a month? The second you start flicking up, you're on a roller coaster that will never end. It will just keep going like this. So why not start earlier? Why not make this a first line treatment? Why not just say, hey, this is not going to go well in the long run. Let's just switch it now while it's easier, and I can show you how much better I can make you feel. Don't be using terms like, the government doesn't want me to do this, or I got to watch, or, I don't want you to develop. No, just say, I want to make you feel better, and this is a way we can do it. Let's do it when it's easier rather than when it's a little more challenging later on. All right. So Now, let's say you've got that patient who's had a little bit of a difficulty. We've talked about this before. I just want to kind of work through this microdose initiation again. Our upcoming buprenorphine chapter in the pain guidance document, we'll be talking about this. All of this stuff will be in there as well. But microdose induction is essentially a way to say, I don't want you to go through withdrawal. I don't know exactly what your dose is going to be. I don't need you to be temporarily uncomfortable as well as anxious because I'm switching you to something that I know is going to be better. We'll just do it at your own pace. So what you do is you use the way that the buprenorphine climbs into the receptor more to your advantage rather than disadvantage, and you just gradually give small doses of buprenorphine, understanding that it's going to start accumulating at the receptor. And then as it starts to accumulate at the receptor, you decide for your patient, or oftentimes I would suggest you let the patient decide for themselves when to stop taking their legacy opioids. That destigmatizes it. It empowers the patient. It's very consistent with motivational interviewing ideas. And, we're attacking this problem together. And there can be some challenges. So you just kind of want to understand what those bumps are. But when you do it this way, the uptake of this is way better. Patients come back to you happier more quickly, and they find their dose. So why do we want to consider that? If you've got an opioid use disorder patient who's not quite there, understanding they're maybe in a little bit of pre-contemplation and they're not really understanding why you want to do this, it works great. You just move it in. It works nicely for a pregnant patient, right? Especially if you have a patient on legacy opioids and you don't want to destabilize their pregnancy with uterine irritability. Buprenorphine is very safe in pregnancy, and this way you avoid any of that kind of thing. Home inductions, really, what it comes down to is also elderly patients where you don't know where their dose is. But I'm going to tell you, number 8 and 9 are kind of the reasons we do this here. For the anxious patient, the overly anxious patient, and the overly anxious provider, it's kind of a idiot-proof way to get people into buprenorphine and to allow them not to worry about it and for you not to worry about it unnecessarily. So this is kind of how we do this. You have a few things you need to kind of tell a patient. One of the problems is don't swallow this, put it in your mouth, let it absorb. Takes a few minutes. Later on, if you want to talk about the dental stuff, fine, but it's not a big deal. Just use this, put it under the tongue. We're going to start very low. We're going to gradually increase it, and we're going to have you help us find the dose that works for your symptoms. We are doing this for your pain. And that's, I think, critical. And then the third bullet point here is probably where we win or lose almost all the time. I tell a patient flat out, I've done this 1,000 times in my practice. I'm excited to get you going because I know you're going to feel better in 3 or 4 weeks, and I can't wait for that visit. You're just going to love it. In the meantime, I'm not going to get it exactly right. Okay? Mr. Jones, I'm either going to go too fast because I want you to get there, or I'm going to go too slow because I'm afraid you don't believe that I'm doing what's right for you. And one way or another, you're going to get some side effects, and inevitably, you'll interpret this as, I don't tolerate that medicine. It makes me nauseated. It makes me jittery. It makes me anxious. I can't sleep. I sleep too much. All of those things that we do are just about me not getting the timing right. It's that transitory phase. So here's what I'd ask. If you're not sure how it's going, give us a call. And don't just say, I can't tolerate it. I hate this medicine, XYZ. Tell me what's going on. Are you having all over body aches? Let's go a little quicker. Or you're getting into withdrawal accidentally. If you say, I'm really nauseated, then what I'm going to say is, well, if I started you on 40 of OxyContin 3 times a day, at the start, you'd have been nauseated with that. You've become tolerant to the anti-nausea effects of your oxycodone. You're not there yet with the buprenorphine. I'm going to give you a little bit of medication to manage that. It'll go away. Let's give you some ondansetron. Let's give you some Zofran. You tell us how long you need it. No big deal. Same is true with constipation. But what we see is patients will say, uh, that makes me a little more tired than I thought. And you say, you didn't understand that it was a 38-hour half-life. So as you were dosing it up, you kind of went right past the effective dose. We just did it a little bit too quickly. So let's just go back down. I have a lot of patients who will take a milligram of buprenorphine once a day. I have a few that take um, a milligram every 36 hours. They're like, that's just how I like it. And, what's the problem with that? That's very easy. But in any event, if you talk about this up front in this fashion, what that allows them to do is first understand that you've been there and you know what's going on and that it's transitory and you're patient facing, right? You're with them to manage the symptoms that they want you to manage. That is the pain and any co-effects that occur, but they're temporary. Don't let them say, I'm allergic to buprenorphine. Could I please have my Dilaudid back? Because, we know that's kind of nonsensical. Um, yeah, you got all this. Uh, this one, I do want to talk about, I'm hoping I'm not going to. Okay. Buprenorphine for cancer pain. Yeah, honestly, we don't use this a lot, right? We expose a lot of cancer pain patients because we're just simply not going to worry about dependence issues developing. If we need to manage their symptoms, we're going to manage their symptoms. And if high doses of opioids work, we should use them. But the same is true to an effect. So I would say there are many times when I see a patient, and sometimes it started out when they come to us because there was a cancer pain, they're now in remission, they've got chronic pain, there's not really ongoing nociception, but that's a great time to get them into buprenorphine. But remember, a lot of what's going on in a cancer pain state isn't just about nociception. And the whole point of treating their symptoms of pain is to be thoughtful and respectful about making people comfortable, as well as avoiding side effects of treatment that or how they feel so that they can stay in their treatment. So sometimes buprenorphine is can be beneficial, and to use it, you kind of have to pay a little bit of attention to do we have a stable situation going on? Will it be changing quickly? But also, I think you need a little bit of confidence that this is actually therapeutically effective. So you'll see a little bit more. We're starting to do this, and it just brings home the point that buprenorphine works great, whether or not we have concerns about dependence. So a few just cases. I'll first, are there questions or does anyone want to have a case? But I just wanted to be sure we had stuff to talk about, or we could talk about the practical aspects of that, should it be helpful.
We can pause for a minute. Any questions for John? You can unmute, drop questions in the chat. We welcome a case from the audience.
It's quite possible I put everyone to sleep as well. It's Friday, but
No.
I'm still awake, Dr. Massey. And
thank you.
thank you for this talk. I do have questions. It's more related to opioid use disorder than the chronic pain. So
Okay.
I can certainly wait until we're done with the
No,
cases.
this is for you. Go ahead, please.
Okay. I had a question about the IM injections of Suboxone.
The sub-Q.
Sub-Q. Okay.
Yeah.
And
Okay.
do you find that there is that is useful or helpful? Again, I'm talking specifically about opioid use disorder.
Um, yes, we do. Um, uh, what I would say is it's patient specific, right? If it's more likely to be consistent treatment for a patient to use the sub-Q version, and they know they just have to come in every 30 days, and that they don't have to make the choice each day or a couple times each day to use the medication. That's a benefit. Um, from a standpoint of pharmacology, my only understanding of the benefit of this is that if you remember, the trough levels of buprenorphine in the CNS is associated with medication ideation. In other words, you want to keep the trough levels above a certain point so that individuals don't start thinking about using in an OUD situation. And
Right.
and the difference between sublingual and sub-Q versions of buprenorphine is that you may have a slightly higher trough level. So it's possible you are, irrespective of how they, taking the medicine twice a day as they should, you might have a little bit of a benefit by increasing the trough levels.
Okay.
I might defer to Todd. Do you have a better answer than that? More accurate answer? Called him out. Sorry.
And then also just in regard to the dental side effects of the buccal film,
Yeah.
is that also for the sublingual or just
So
the film?
yeah, it's in the mouth, right? It's acidic in the
Mhm.
mouth.
Okay.
And here's what I think about that. You can manage this, right? We're not dosing this all the time, and it's 10 or 15 minutes of an acid, which is not great for the enamel in your mouth.
Okay.
What I think people use that for is uh, my doctor wants me to get an OUD treatment, and I don't know about it. I'm going to get on Google and look. And you can be sure that there are millions of people who say, no, it causes cavities. My teeth fell out. Never mind the fact that they used methamphetamines for 10 years as well. It's a chance to have a discussion saying, well, overall, healthy management is important. And there's a lot of things, I'm drinking coffee right here, right? That's not that great
Mhm.
for my enamel today. I better take care of that. Um,
Okay.
should not be a limiting factor if this person's serious about what's going on. So, use it as a chance to deflect it, say, yeah, things could happen. However, we can prevent all of that with the right management and just have that open discussion. And by the way, how'd you get to that? Oh, yeah, you were Googling that. Well, there's risks of that, right? Context is key.
Okay.
Great
Perfect.
question. Great question.
And then, sorry, just one more quick one. The onset of action for acute pain, you
Mhm.
were talking about kidney stones, and
Yeah,
it has the same effect. If you give the Suboxone, can you expect that they will have relief in the emergency room?
yeah. Most
Okay.
of the time you can. There's a lot of medications that we use that have an analgesic efficacy of 6 or 7 or 8 hours. So
Hmm.
Um, as, I wouldn't expect it with the patch, right? That takes about 12 hours for onset. Um, I, when for example, patient calls, they had some surgery and the surgeon said, call the doctor that's got your pain contract. I'm not going to give you anything. I had three teeth pulled. I really hurt. Take an extra half a milligram of buprenorphine. Thanks. And
Okay.
it's like we're giving them, it's a little slower. They don't feel all the effects right away, but it's perfectly acceptable in an ED setting.
Thank you very much.
Yeah.
Hey, thanks, Michelle. Denise, I see you raised your hand. Do you have a question?
Yes, thank you. And Dr. Massey, this wonderful information. I apologize if you covered this already because I was late joining, but I'm accustomed to prescribing Suboxone for opioid use disorder, and have had, of course, good coverage with that with insurance,
Hmm.
with especially in medicated population out
Yeah.
of state. But then
Yeah.
when I started using it for pain control,
Uh-huh.
I did everything was great. I had the patient was ready to start it, and when she got to the pharmacy, it was going to cost her. I mean, it ended up costing over $100 just for a couple of weeks.
Okay.
She was not going to be able to afford it. We ended up
Sure.
getting it covered for her, so I didn't know if you had some advice on that.
Yeah, absolutely. And thank you for that question. I really didn't cover that, and I should have. Here's the thing. Uh, uh, Transdermal buprenorphine is covered and even isn't always different in price from, oxycodone or what have you, including Medicaid in the state of Nebraska anyway. And so you can get a patient to up to 480 micrograms transdermal a day. Um, give you some context, 5 micrograms an hour or 170 micrograms a day of buprenorphine roughly translates to hydrocodone TID. So you can get them like 7 Percocet a day equivalent MME with the transdermal that's covered at $60 a month or less than that. What I often do though, and I think it takes a little bit of time to understand how this can work for that kind of an economic issue for a patient. You know, the film, the 2 milligram film of, I'm looking at this because that's where my speaker is. For some reason, I thought you were coming for the 2 milligram film of buprenorphine is easily cut into quarters, which makes it 0.5 milligrams a day. And 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 so what you can easily do is just give an individual a single 2 milligram film, uh, and that gives them 4 days or 2 days of dosing at 0.5 BID. So they're using 15 strips or even 8 strips a day, a month of buprenorphine film, and you know the price of that with cash is cheaper than legacy opioids. So that's when
So you,
that's where you get crazy because Belbuca is, you know, you can get coupons for Belbuca, which is from 170, 150, 75 to 900 micrograms a day, or you could just give them a generic buprenorphine and they can cut it in a half or a quarter and it's 1/10 the price. Welcome to healthcare.
okay, that's what actually I had prescribed was the films, and it was pretty
So,
pricey. So this
well,
is
no,
through Blue Cross. But
so I would say 2 milligrams sublingual, uh, up to 1 BID, and then just know that the patient's going to take a quarter or something like that. And you could do the same with the 8.2s.
yeah,
You can get them that, you know, you will see that they pay $50, you know, a month or something like that, but they're paying that for
yeah,
their other medications too.
yeah, that's true. And but just to clarify, you said the transdermal is usually uh better coverage or less expensive.
The it I haven't looked. Yeah, the transdermal, you know, it's the generic Butrans, the buprenorphine transdermal, you know, 5 to 20 micrograms an hour, 175 to 480 micrograms a day, is preferred on those kinds of plans. So
Perfect.
it's they can get it. It if it gets to be, you know, if somebody says, look, I can't spend $40 a month, then they might be telling you something different than it's really the money.
That makes sense. Yep. Thank you so much.
You bet. Good question. I should have brought that up.
Okay, if we got time for one quick question, Dr. Massey, one in the chat from Ingrid. How do you counsel about the onset action of Butrans? I heard that it was 48 to 72 hours. Is it faster than that?
Uh, it, when it's 48, it's not. It's 12 hours, but really what's going on in that situation is that the patient is experiencing what's good about the transdermal, the Butrans. It's that the efficacy can be there without the sense of I'm being medicated. They're feeling that the medication effects, which are side effects from the opioids, are going away, and they're getting to the benefits without those effects. Or probably equally likely you're underdosing a bit, which is a reasonable way to go. So nothing wrong with starting somebody on Butrans while you co-prescribe their you know, opioids for a week or so. Don't be afraid to do that. That's a very rational way to get this. So if they're really worried about that, just say, you know, for the first couple of days, just take it, and then we'll just take it away when you start to feel you don't need it. I liken it to lifting up the training wheels on a bike and tricking a kid into learning how to ride a bike without knowing it.
Great. Well, thank you, John. Looks like we are at the end of our hour here. I dropped a link to the evaluation survey. You can complete that to get your certificate for today. I'll also be emailing that out. My email may come a little later than normal today, but it'll be coming out at some point later this morning, probably. And yeah, like I said, we're off for September, but then back in October and November. So keep an eye out for some information about that next series. Thanks, everybody. Thanks, John.